Hello, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, on behalf of the International Cardio-Oncology Society. Today we present highlights from a recent webinar discussing the cardiotoxicity that may be associated with current treatments utilized across the complete spectrum of breast cancer presentations. Our presentation comes from Dr. Paul Cottu. His talk looks at cardiotoxicity from the point of view of a treating oncologist. Just a reminder that the ICOS website remains the single best source for cardio-oncology information, including information on programs and board-certified specialists in the field. You can find the website at ic-os.org. And now, without additional delay, here are our highlights from Paris.
Okay, hello everybody. I think you hear me. So my name is Paul Cottu.
Yes.
I'm actually a breast medical oncologist in Paris at Institut Curie, which is a comprehensive cancer center, one of the 18 comprehensive cancer centers in France. And we work closely with the cardiology team from the Institut Montsouris, which is located close to Curie, with Francesco and Dr. Mirabel here today. So I have the privilege to give the first talk. And again, thank you very much to your society and the organizers for inviting me to deliver this talk. So this is a quick overview of the current treatments in breast cancer, whatever the stage, with a focus on cardiac toxicity. So I don't know if it works. Yes. So briefly, just to set the frame, breast cancer is divided into three main categories, which are defined by some molecular characteristics. And within breast cancer into luminal A or B according to the proliferation status, HER2, which refers to the amplification of the HER2 gene, and the basal-like, which are more currently called triple negative as ER, so the estrogen receptor, PR, the progesterone receptor, and HER2, the third receptor, are not expressed or overexpressed in the cancer cells. And you see here that the treatments that we use for those cancer, mainly the medical treatments, I'm a medical oncologist, are based on these subcategories and are driven by these molecular characteristics. So we use chemotherapy for a vast majority of breast cancer patients, not all of them. We use HER2 targeted therapies, and I guess you're familiar with these therapies in a subset of luminal B and of course all HER2 amplified breast cancers. And we use endocrine treatments in all patients who express either ER or PR in the cancer cells. To move on, and I have divided the talk in the two main topics in breast cancer, whether the cancer is localized to the breast and the axillary lymph nodes, what we call early stage, or becomes metastatic later on. So we use guidelines, and these guidelines are very frequently updated. And this is an example from the ESMO, the European Society of Medical Oncology. And you see that the medical decision is driven by, again, this molecular subclassification of breast cancer according to the expression of ER, the estrogen receptor, or HER2. And basically, bottom line, you see here at the bottom of this tree, the categories of treatment that we use currently according to this molecular subclassification. And you have new and old drugs that are used here. And just to remind you that to go along these drugs, please do not forget endocrine therapy. We have now extended the use of aromatase inhibitors to virtually all ER-positive breast cancer patients, at about 75% of patients, so the vast majority. And we have also extended the treatment in duration because we have now demonstrated that for a subset of patients with long-term high risk, to go over the 5 usual years of treatment with endocrine treatment is beneficial with regards to the relapse rate. And there are several data suggesting that aromatase inhibitors, when compared to the old drugs such as tamoxifen, are or might be detrimental with regards to cardiotoxicity. The forest plot that you see here are divided according to the different kind of trial designs that were used to definitely implement the aromatase inhibitors in the early breast cancer setting. But you see that whatever the trial, there is also a detrimental effect of the aromatase inhibitor with regard to, generally speaking, the cardiotoxicity, and this is to be kept in mind. Next, of course, and I will not go over all the old history of chemotherapy and cardiotoxicity, of course, anthracyclines, but also other drugs, which sometimes are maybe not just as considered as they should be with regard to toxicity. And you see that virtually the vast majority of the major conventional cytotoxic chemotherapy classes of drugs may be or may expose the patients to some kind of cardiotoxicity, and usually considering the cumulative dose, including the dose that the patients may have received in the past, even 20 or 25 years before. Next, moving to the HER2 blocking agents, and I didn't want to go through the whole history, but just to give you an example of what we are facing in the daily practice. These are data that are derived from a study which is called PERUSE, which used on the in a real life setting. So you see more than 100 patients, the combination of trastuzumab, which is a monoclonal antibody directed to HER2, and pertuzumab, which is also a monoclonal antibody directed to HER2. And now we use these antibodies in combination. About 15% of patients do experience at some point some kind of decrease of the left ventricular ejection fraction. And you see that this toxicity comes after a whole bunch of other toxicity, which are much more frequent, but which are usually less limiting for the use of these drugs. You see also that some hypertension may be observed in this large cohort of unselected patients receiving this double antibody treatment, which is absolutely current practice now. If we move now to advanced breast cancer, and I have divided into the three parts. So ER positive first, then HER2 positive, then triple negative. These decision trees show how we should use the currently available drugs in advanced ER-positive breast cancer according to the line of treatment. So what is stated here is that usually in first line, and this is the green box here, we have to use a combination of ET, endocrine treatment, plus a CDK4/6 inhibitor. So CDK4/6 inhibitors are a recent class of oral drugs which have been developed historically in leukemia, but which were development was stopped because of general toxicity. And second and third generations of CDK4/6 inhibitor have now been developed and validated in advanced ER-positive breast cancer. Usually, these drugs are very well tolerated because they target very specifically kinases which are linked to the beginning of the cell cycle, which are specifically involved in the cell cycle progression in ER-positive breast cancer. And they have some kind of limiting toxicity regarding neutropenia. And we will see thereafter there is also some specific cardiac toxicity that we may be facing. We also use another drug which is called everolimus, which is an inhibitor of mTOR. mTOR is a general sensor in the cancer cell, which has also ubiquitarious function in normal cells, of course. And you see also that we can use PARP inhibitors. PARP is an enzyme which is used in DNA repair system with the homologous repair system. And in patients who are deficient for the BRCA1 or BRCA2 genes, which are the most common encountered genes in genetic predisposition, the PARP inhibitor is useful in those patients. And we are now entitled and we have the approval for PARP inhibitors. So if we want to give a quick look to these drugs, which are not commonly associated with cardiac toxicity, we may pay some attention to that. First, everolimus, which is mainly used in advanced breast cancer, is associated with, for example, high cholesterol or hypertriglyceridemia, which may be observed as well. And for those patients who may be exposed to long-term everolimus, of course, this might be of concern. Next, moving to ribociclib. So ribociclib is one of the three CDK4/6 inhibitors I was referring to a couple of minutes ago. And one of the specific cardiotoxicity which has been observed with ribociclib and not with the two other, because there are some subtle pharmacological differences between these three drugs, is a prolongation of the QT interval, and we usually the QTCF formula to qualify the QT prolongation in patients. Please note also that two doses are currently used for ribociclib, either 400 in the adjuvant setting or 600 rather in the metastatic setting for milligram for ribociclib, and this is the daily dosing. Moving from 600 to 400 has clearly downstaged the amount of QTC prolongation that we are facing, but you see that about 5% with 600 and maybe 1% with 400 patients, 400 milligram may be exposed to QT prolongation. And speaking of that, just to remind you, and of course, I'm sorry, this is a busy slide, but the message here is that many oncology drugs, whether anti-cancer drugs, and this is the majority of the table here, or anti-emetic drugs here may be also associated with some level of risk of QT prolongation, meaning that we have to pay caution to that, and Mariana is quite sensitive to that. We do the ECG, the cardiologic evaluation, when we think that there is a risk of QT prolongation, and also we consider, of course, the pharmacological interaction with other drugs. For PARP inhibitors, there is also a risk, which is not completely defined yet, but we have emerging data from several studies, mostly in ovarian cancer and some in breast cancer as well, again, suggesting that the control arm is less exposed to major adverse cardiovascular event, that is, for example, myocardial infarction and so on. Any grade, it's true. It's reassuring to see that for high-grade risk, usually it's about the same. So this is a slight cardiotoxicity, but which, again, has to be considered. Other cardiologic events may be observed with PARP inhibition, for example, hypertension or thromboembolic events as well. And there are differences when we compare the arms of the trial with PARP inhibitor versus the control arms. And one potential explanation for this, because we don't see really a direct biological explanation with regard to the mechanism of action, to the mode of action of the PARP inhibitors, but rather this might be some pharmacological interaction with for example, the dopamine or the norepinephrine metabolism. And I cannot directly comment on that, but I would be happy to discuss on this hypothesis with cardiotoxicity for these drugs. Also, these drugs, and this is also true for other cancer drugs, but this was not obvious at the beginning of when we implemented these drugs in the practice. You see that about 5 to 6% of patients may require blood transfusion, and this can, of course, cause indirect cardiac events. If we move now to HER2-positive breast cancer in the advanced setting, what I said before regarding chemotherapy or HER2 blocking agents such as trastuzumab or pertuzumab remains true, of course, in this particular clinical setting. So this is everything is in the blue boxes here. What you see here is there is a newcomer, which is called tucatinib. Tucatinib is an oral drug. This is a specific tyrosine kinase inhibitor of the tyrosine kinase function of the HER2 gene, which is given orally. But it has not been observed an excess of cardiotoxicity with these drugs. You see here the main table from the main study, which has validated the use of the tucatinib in HER2-positive advanced breast cancer patients. So there is no cardiotoxicity here. And you see when you deep down in the paper some hypertension which is observed, but clearly there is no specific difference versus the control arm. So nothing special with tucatinib, which is becoming widely used in HER2-positive cancer. The only thing here is that tucatinib is used with trastuzumab in combination, so we pay attention to trastuzumab as usual. I will skip that. Next, we move to triple-negative breast cancer. And this is the case to see, again, new drugs, innovative drugs that are now very widely used in triple-negative patients. And also some of them you see in other cancer subtypes. First, pembrolizumab. So pembrolizumab is a PD-L1 inhibitor, so it's one of the most important immuno-oncology drugs, which is approved in many cancer settings, including now both advanced triple-negative breast cancer. This was the first approval. And this is also now approved in early stage triple-negative breast cancer. And you see that this has led to a rapid recommendation from ASCO, the American Society of Clinical Oncology, which is our global oncology society across the world. So pembrolizumab, as many immuno-oncology drugs, is associated with some cardiac events. But some only, but we know that myocarditis, which is the most frequent cardiac event, this is not the most frequent adverse event from pembrolizumab, but probably the most frequent cardiac event, is rare, less than 1% or about 1%. This is true in combination with chemo. This is what these tables refer to. You see, this is myocarditis here is at the bottom of the table, so meaning that the frequency is not that high. And this table refers to the second part, so in patients who have pembrolizumab only, not combined with chemo. And again, myocarditis is less than 1%. So taken together, and if we, to make a story short, if we consider all immuno-oncology agents in oncology, generally speaking, and pembrolizumab, which is the only approved IO drugs in breast cancer, myocarditis is rare, but the problem is that it's potentially lethal, which is not true for other adverse events, for the most frequent adverse events with pembrolizumab. So overall, 1% incidence at most, but 50% mortality. And you know better than I do how to manage this adverse event from IO drugs. And last but not least, ADCs. What are ADCs? ADCs are antibody drug conjugates. So what are those drugs that are now widely used in oncology? This is a combination of an antibody. You see the Y form on the antibody here, which is combined with a chemical linker with a conventional cytotoxic chemotherapy. So in breast cancer, there are two ADCs that have been approved. The first one is sacituzumab govitecan. The target is a membrane cell antibody, which is called TROP2, which is quite ubiquitous in many cell subtypes, both malignant as benign. And we conjugate this antibody directed to TROP2 with a drug which is called govitecan. Govitecan is a derivative from irinotecan, so comptotecin, which are topoisomerase 1 inhibitors. As far as we knew, this class of drug had no cardiac toxicity, and this is true as well for sacituzumab govitecan. But just to set the frame, you see we have only here respiratory, thoracic, mediastinal adverse events, so nothing very specific, which might be also related to either the disease or other general complications. Now we move to trastuzumab deruxtecan, which is very important. Trastuzumab deruxtecan is an ADC combining trastuzumab as the antibody and deruxtecan as the cytotoxic drug, which is close to govitecan. This is also a topoisomerase 1 inhibitor. The question here is that this ADC uses trastuzumab. So we were wondering whether the combination of a drug which is chemically linked to the antibody could enhance the level of cardiac events. This is not true, but there is no specific protection as well. You see here that overall, the left ventricular ejection fraction dysfunction is about 4% in the DESTINY studies. The DESTINY studies are all the studies who evaluate deruxtecan, trastuzumab deruxtecan in breast cancer. But this is also true now in lung cancer. This is becoming true in colon cancer as well. So this is across the cancer field that you will be facing patients with trastuzumab deruxtecan. Most of these dysfunctions are grade 1 or 2. They are not that frequent, as you can see, but some, of course, may be more serious. So bottom line, this is not very different from what we had observed with trastuzumab alone, and there is no excess of cardiotoxicity with this new class of drugs. This is important because you can see here the amount of targets, so the antibody part, and of drugs. So this is the cytotoxic compound, so what we call the payload, which is combined to the antibody, that are either developed or in development. So the first ADC, and this is, you see this history line here, which has begun about one century ago when the concept was designed by somebody very important who is called Paul Ehrlich, who was in 1910 launched the concept of the what he called the magic bullet. But it has taken almost 100 years to develop these drugs that are amenable to the clinic. So now we've been using these drugs for 20 years in oncology and a couple of years in breast cancer. And you see the vast list of treatment that have been approved. And there are more than 100 which are currently under development. So we have to be aware of that. So to summarize, regarding breast cancer drugs and cardiotoxicity, there are old drugs that we are all familiar with, anthracycline, furoperimidine, and so on. HER2 blockades, of course, whether they are IV or oral drugs. And I have skipped the questions about radiation therapy that we continue to use. The question with radiation therapy is that now we use conformational methods, and I am not a radiation therapist, who clearly spare the heart and which should not face long-term cardiotoxicity as it was the case in the past. Immuno-oncology drugs are both recent and future because there are all other immuno-oncology drugs which are currently under development in breast cancer as in other cancer fields. Ribociclib is the CDK4/6 inhibitor with the question about the QT prolongation, which is, of course, a limitation. And ADCs are both recent and future, as you have seen, because of the many ADCs that are currently under development. And finally, the cell therapies are not very mature in breast cancer. They are just under development. But we are going also to face this specific cell therapy in breast cancer in very probably limited indications, but with a high potential for cardiac toxicity for our patients. So to summarize, and again, going back to the beginning, so you have the four subset of breast cancer. Chemo, HER2-targeted endocrine therapy, this remains absolutely true today with all the caveats regarding heart that we have discussed. And just keep in mind that targeted therapies, PARP inhibitors, CDK4/6 and others, or ADCs will encompass the whole breast cancer field, meaning all our patients will probably someday be exposed to one or two or three of these classes of drugs. And I thank you for your attention.
That certainly was an interesting and very patient-centered review of both breast cancer treatment and the potential cardiotoxicity associated with those treatments. Thank you for listening, and on behalf of ICOS, this is Dr. Tom Murtaugh reminding you to treat cancer, protect hearts.